I have the pleasure now of being joined by Dr. Raj Keswani, talking about the ASGE Symposium on legal issues facing gastrointestinal endoscopy. And I know one of the things you're going to be discussing, and it's very critical, is this idea of limiting liability.
Yeah, I think this is an interesting idea for the ASGE to have this symposium. We actually have two world experts speaking on topics in gastrointestinal endoscopy, ERCP and colonoscopy, and how, as physicians, we can limit liability. And that may sound sort of strange to you, but there's a lot of components to that. I think you think a lot of this is common sense, but obviously, as you know, many people don't always use common sense when it comes to what they need to do. One of the ways we have to think about limiting liability is consent process. So when you talk to a patient, have you developed an actual understanding, or as a patient developed an actual understanding of what's happening for them and why, and what the risks are? And so both for ERCP, where Dr. Cotton is a world expert in ERCP and its sort of associated quality and safety, and for colonoscopy with Dr. Hernandez, we'll be speaking about similar issues, we need to think about the consent process. But there's also other ways, we can limit liability. There's the idea of just if something does happen that shouldn't happen, and adverse events do happen. We do a lot of procedures and some things do happen. The real key is to communicate with the patient, and that's essential. There's this repeated concept you'll hear about during this session is don't run away when something happens. Tell the patient what happened. Oftentimes lawsuits occur because patients simply want to know what happened during this procedure that resulted in an adverse event.
That communication process is so important, but some patients can be challenging. Mm-hmm. So how do you advise people to deal with perhaps the more difficult of the patients?
Right, I think no matter how challenging it is, it's clearly going to be better to talk to the patient afterwards. There's a lot of interesting work that's coming out from other centers where they actually just talk about being full disclosure, proactively explaining everything that happened. And that actually has been shown in some studies to actually reduce your medical malpractice costs by actually just being proactive about being with disclosure. But there are always people in our hospitals that can help us through difficult conversations. It's difficult even when the patients are relatively easygoing and their families are easygoing, because you feel bad. Anytime something bad happens, you feel bad as a physician. That's why we went into medicine, to help people. But we have to work hard towards getting that sort of communication to be effective.
It is an exciting time in the sense that there is some new technology available, but how do you make sure that you can adopt that? Do you need certain credentials and to just be safe overall? Right,
I think it goes to sort of both aspects. So you have to know your own personal limits with what you feel safe doing, even for the standard stuff we do. And again, just to go back to the ERCP talk, Dr. Cotton has been a big advocate of if you don't perform this procedure at a high enough volume or at a high enough technical proficiency, you should be referring it elsewhere or consolidating to physicians who can do it with higher success rates. But then this expands into this whole area. Gastrointestinal endoscopy is extremely exciting right now. There's a lot of devices to treat diseases that we never thought we could. Obesity, you'll hear a lot about at DDW. How do we treat obesity endoscopically? But once we have these new devices, it's actually not particularly clear how a hospital credentials us to utilize these devices. Who in the hospital actually is qualified to say, you went to a course, you did it a couple of times, and now you're going to come back and do it in a patient. And that's where societies like the ASGE are really going to be helpful, because they have the expertise in understanding what it takes to do these procedures, because a lot of the people who are teaching these courses have helped develop these devices, and they can help develop more comprehensive teaching programs. And ideally, we could have hospitals partner with societies to really try to ensure that when we disseminate this technology widely, that it's performed to the highest capacity it can be performed. But that is a challenging area, I think.
Clearly physicians are focused on their patients and doing the best job for them, but they need to think about some of these other bigger picture items. What advice would you give to attendees here?
So I think the biggest thing, and I'm going to stress this again, is always communicate. And I think communicate isn't just to the patient. So I would communicate to the hospital. If you're going to bring in a new device, make sure the hospital knows this has not really been utilized before in patients at this hospital before, and try to understand what you would like me to do. If an adverse event happens, make sure you communicate to your colleagues, your physicians. For example, if I have a colonoscopy and I have a perforation, I may tell the surgeon, I think I've treated this well endoscopically, you don't need to operate. If that communication doesn't exist between disciplines, you can end up having more problems than you want. And obviously, as we talked, you need to communicate with the patient, both about, have I done this before? And what my success rate is, and what you can expect as a patient. Patients will be upset if they didn't know that there was a complication that could occur. But if you've given them true informed consent and they've agreed to the procedure, that's more important than them just signing at the dotted line saying, sure, go ahead and do it.
Exactly. Great advice, Dr. Keswani. Thank you so much.
Thank you for having me.